I'll be introducing the lens and talking on my experience with AddOn. And we got a plethora of experts on all the different designs of the other lenses, and they'll be talking on that. And we'll have Dan Athavale giving the new adopter experience in his world. So if we look at this platform, and it's a combination of either hydrophilic or hydrophobic acrylic, and it's got a design that maintains good centration, easy to rotate, and is stable in terms of rotation. So this is the toric form, and you can see the two haptics which can be compressed quite comfortably without decentration. And we've got the EDOF form, and Alison and Joaquin will be talking about that. And Banu will be talking on the multifocal design. So just quickly to understand, the Elon is a wavefront linking zone. It is a small central elevation which drives the wavefront on the anterior surface, and it's predominantly distance and intermediate. And we are using it more and more in the presbyopic population. The multifocal is a standout lens because of its reduced number of rings and very low dysphotopsia. And I'll be just talking about my 1stQ AddOn experiences, and I've been pretty brave in this field. So first of all, this lens is Sulcus based, and a competitor equivalent is something like a Sulcaflex. But the advantage of this one is complete rotational stability, whilst my issues with the Sulcaflex in the past have been rotational instability. Sometimes even have to suture a haptic to an iris. Well, you don't have to do that in these AddOn lenses. So you can use it as many modalities. First of all, there's the multifocal, which is actually 6 rings instead of 7, and is just as effective as 7 rings in the bag. And a combination is the dual lens system, where you have a monofocal in the bag, and you've got your multifocal outside the bag for reversibility. But then you can add any power into the Sulcus if you're doing refractive adjustments post-cataract surgery, and this can be a toric, it could be plus or minus powers, and you can get it custom made. Then we've got the SML lens, which is a magnifying system, an incredibly useful tool. I've done about 5, which is not a lot, but the dramatic effect and the advantages to the patients who have macular disease is very powerful, and we'll go through that. So there's the story on rotational stability, and I can promise you it is rotationally stable. I've never seen one rotate out of axis. And I've used the lens in the cohort where you think this patient is not suitable for a multifocal or borderline, and the patient has issues. They're thinking, I don't want to lose an opportunity of getting my vision completely independent, but what if? Or if they have a history of macular degeneration in the family, and you found 1 or 2 drusens and they're in their 60s, are you going to exclude them from multifocality for the rest of their life? So in those borderline cases, I will offer multifocal reversibility. And I've done at least close to 100 of those. Toric powers in the Sulcus space, I will use in abnormal corneas, usually with irregular astigmatism. When you measure the astigmatism across different diagnostics, you can't work out the power, you can't work out the exact axis, and you're uncomfortable with using toric in the bag, because now what are you going to do? Change the whole system. So what I do, I reserve the toric power for outside the bag, because I can either rotate it or remove it and then put in another one. Then the magnifying effects I've explained, which is the SML. And the last one, managing negative dysphotopsia, I'm not talking about that because it's going to be in the scientific program in the 8:30 to 10:30 slot. So dual lens concept, two lenses, but it's a non-traumatic reversibility. If the person says, I hate these dystrophies, I can't cope, don't worry, we'll make you monofocal. And in the bag, very important, hydrophobic. Okay, we don't want hydrophilic in the bag because we know, Jared showed us, polypseudophakia with hydrophilics can eventually calcify. So we did 1 year data of comparing Liberty in the bag, Liberty and Liberty toric versus monofocal in the bag and the add-on outside. And these two groups were compared over a year, and I had absolutely no difference in results. In fact, when I studied the positioning of the rings, you worry, if it's in the sulcus and the sulcus shape is slightly ellipsoid or not perfect, are we going to get a decentration of the rings? I never saw one decentration. So I'm very comfortable that when you put the add-on multifocal component in the sulcus and you set it on those Purkinje images, it will stay there. And the add is 1.5 and 3. And as I said before, the rings for the sulcus add-on is 6. Obviously, you have to have done your homework. We can't put an add-on in everyone. You have to know all about the zonular condition, and you need adequate pupil and adequate AC depth. And these are the toric ones that I looked at, which were in the abnormal cornea population. And it's there because I may want to change the toric. Or what happens if the patient comes to a graft and now we've got a huge refractive misalignment. How are we going to repair this? So you can go to the bag, outside the bag to the sulcus, and you get good results that way. So when we look, just remember these are abnormal corneas, so not everyone's going to be 6/6/20/20. And the 12-month data was very consistent in terms of good distance visual acuity. And we looked at the spherical equivalent. 75% were within 0.5 diopters, which is pretty good. And the refractive cylinder showed that we did correct the power, and we did well there. And if we look at the centroid of dispersion of the astigmatism on the left and what we landed up a year later, we have effectively corrected the astigmatism properly. So it's a very useful tool, and I would recommend it. So the SML is for stable scars. So if we look at vitelliform or a little bit of dry macular disease, but not someone who's got profound damage. And there are clinical indicators which we'll go through on how to choose this. So there's a 10 diopter zoom component right in the center, which delivers about 6 diopters of power at 15 centimeters. So these are the patients who've got reading glasses, and if they want to see something really well, they take the glasses off, and they'll bring the reading material to their SML eye like this, and they will scan, and they'll see a lot better. And they're profoundly happy. So this is how we do the workup. The best corrected vision in the better eye has to be somewhere between 618 and 660. But to be honest, it's usually 618, 624. That's the population I'm looking for. Patients read at 40 centimeters with their normal add, right? Then we take away all their glasses and their add, and we just put in a +6 diopter at the equivalent back vertex distance and say, now what can you read? And we bring the target to 15 centimeters. And if there's 2 lines or more improvement, they're a candidate. And of course, they all pseudophakic. So this is a gentleman who's 83. He has had a combination of dry and wet disease. And he's had his cataract surgery years back. And he's on injections, and he's getting more and more frustrated. So you can see the scar. on autofluorescence, and you can see the OCT shows there's loss of retinal cells and significant RPE atrophy. But he passed the test. So he was 618 pre-op. Post-op, he was 621, but with a minus 0.5, he was back to 618. So he did not notice a shift in distance vision. But his reading vision jumped. So he was N8 and binocularly N6 when he was reading at 15 centimeters, and he used it all the time. Then finally, the last one is the add-on plano lens to correct negative dysphotopsia, but that is for in an hour or two's time.
Brian, thanks for showing the broad-ranging applications of the lens. One question, one comment. The comment is, with the anterior chamber depth, I'm sure you're not putting in many hypermetropic multifocals because of the ACD exclusion. The second thing is the UGH.
Yeah.
What's the incidence of that?
So that's a good point. And I think the design features stop us seeing UGH or UG syndrome. And the issue, there's no bolting, so it's a plano lens. And the point of touch is so minimal. There are 4 haptics with only just a minor touch to ciliary body, rather than a C-loop, etc. So I think it's pretty safe. I haven't seen one.